Good morning, everyone, and thank you for being here today. I'm pleased to welcome you to this presentation on Ckd, mineral and bone disorder, or Ckd Mbd. My name is Dr. Asim Hussein. Over the next few minutes, we'll explore the key aspects of this important condition, including its causes, effects, and management strategies. I look forward to sharing valuable insights with you, so let's get started. Let's look at this case carefully. We have a 62-year-old man with stage 4 chronic kidney disease who is presenting with bone pain and pruritus. His labs show a calcium level of 2.05 mmol per liter, which is slightly low normal, and a phosphate level of 2.2 mmol per liter, which is within the normal range. His PTH is markedly elevated at 680 pg per milliliter. Now, considering these findings, what does this tell us about the underlying mechanism? First, the high PTH suggests secondary hyperparathyroidism, which is common in advanced Ckd. The bone pain and pruritus can be related to mineral metabolism disturbances. The key here is to understand how Ckd affects calcium and phosphate balance. In Ckd, the kidney's ability to excrete phosphate diminishes, leading to phosphate retention. This retention then causes a decrease in active vitamin D, or calcitriol, because the kidneys can't hydroxylate vitamin D effectively. Reduced calcitriol impairs calcium absorption from the gut, which can result in hypocalcemia or low normal calcium levels, stimulating the parathyroid glands to produce more PTH. This process is a classic example of secondary hyperparathyroidism caused by phosphate retention and decreased calcitriol in Ckd. So, the most accurate answer here is that phosphate retention with decreased calcitriol is driving the elevated PTH levels and the clinical picture we're seeing. Connecting this to the broader theme, it highlights how Ckd disrupts mineral metabolism, leading to secondary hyperparathyroidism, bone disease, and other complications. Let's break down why the correct answer here is C in chronic kidney disease, or Ckd. One of the key issues is phosphate retention. As kidney function declines, the kidneys can't excrete phosphate effectively, leading to an accumulation in the blood. This phosphate retention has a significant impact on calcium levels because high phosphate binds free calcium, reducing the amount available in the bloodstream, which causes hypocalcemia. Now, another critical point is that the kidneys are responsible for converting vitamin D into its active form, 1-alpha-hydroxylated vitamin D in Ckd. This process is reduced, meaning less active vitamin D is available. Since active vitamin D helps the gut absorb calcium, its reduction further worsens hypocalcemia. These changes, phosphate retention and decreased vitamin D activation, set off a compensatory response, secondary hyperparathyroidism. The parathyroid glands release more parathyroid hormone to try and restore calcium levels, but this is a hallmark feature of Ckd Mbd, or chronic kidney disease mineral and bone disorder. So, in summary, phosphate retention and reduced renal activation of vitamin D are central to the development of hypocalcemia and secondary hyperparathyroidism in Ckd. And that's what defines Ckd Mbd. All right, let's take a look at this question. We're asked about a 55-year-old woman with stage 3 Ckd who's asymptomatic, and we're considering what abnormality in mineral bone disease would be detected first. Now, in Ckd, the mineral and bone disorder progresses through a sequence of changes. Early on, the kidneys start to struggle with phosphate excretion, leading to phosphate retention. This triggers an increase in parathyroid hormone, or PTH, as the body tries to maintain calcium and phosphate balance. So, even before any symptoms or significant changes in calcium or bone structure, the first detectable abnormality is typically an increase in PTH levels, what we call secondary hyperparathyroidism. This is why, among the options listed, hypocalcemia, hyperphosphatemia, elevated PTH, low alkaline phosphatase, or bone fractures, the most likely first abnormality to appear in this context is an elevation in PTH. It's a compensatory response that happens early in Ckd-related mineral bone disease. So, recognizing this early PTH elevation is crucial for proper management and preventing further bone complications. Correct answer, C. Now, let's discuss why that's the right choice. PTH, or parathyroid hormone, tends to elevate early in chronic kidney disease. What's particularly interesting is that this increase in PTH happens even before we see clear abnormalities in calcium or phosphate levels. So, in the progression of CKD, PTH elevation is one of the earliest hormonal changes. This is important because it can serve as an early indicator of mineral and bone disorder, even before the more obvious lab abnormalities appear. Understanding this helps us grasp the sequence of metabolic changes in CKD and highlights the importance of monitoring PTH levels early on. All right, let's take a look at this case. We have a 70-year-old patient on dialysis who's experiencing bone pain. Their labs show a PTH level of 45 pg/ml, which is within the normal to low normal range, and a low alkaline phosphatase level. This is interesting because, in many bone disorders related to kidney disease, lab values can guide us toward the correct diagnosis. For example, in secondary hyperparathyroidism, we usually see elevated PTH levels, often quite high, as the parathyroid glands respond to hypocalcemia or vitamin D deficiency. But here, the PTH is relatively low, and alkaline phosphatase, which is a marker of bone turnover, is low as well. That suggests decreased bone remodeling activity. Now, considering the options, osteitis fibrosa cystica is associated with high PTH levels, so that's unlikely here. A dynamic bone disease, on the other hand, is characterized by low bone turnover, low PTH, and low alkaline phosphatase, fitting this patient's profile perfectly. Osteomalacia involves defective mineralization, which typically presents with high alkaline phosphatase levels, so that doesn't fit. Paget disease usually causes increased bone turnover, so higher PTH and alkaline phosphatase are common there. So, connecting all these points, the best explanation for this patient's findings is a dynamic bone disease, which is common in dialysis patients, especially those overtreated with vitamin D analogs or calcium. This example highlights the importance of understanding the different bone disorders associated with chronic kidney disease and how lab values help us differentiate among them. The correct answer here is B. What we're seeing with suppressed PTH levels combined with low ALP is indicative of low bone turnover, which is a hallmark of a dynamic bone disease. This condition often occurs as a result of overtreatment, especially in patients with chronic kidney disease who might be receiving excess therapy for mineral management. It's important to recognize these patterns because they tell us a lot about the bone's metabolic activity, or in this case, the lack of it. Connecting this to the overall theme, understanding these lab findings helps us tailor our treatment strategies to prevent further bone complications and optimize patient outcomes. All right, let's take a look at this question. We have a 68-year-old patient on hemodialysis who shows extensive coronary and aortic calcification on CT imaging. The key question here is, which biochemical factor most strongly contributes to this kind of vascular calcification? Now, considering the options, we need to think about the pathophysiology involved in vascular calcification, especially in patients with chronic kidney disease. It's well known that disturbances in mineral metabolism play a central role. Looking at option A, low serum calcium, this is less likely because low calcium doesn't typically promote calcification. In fact, it might have the opposite effect. Option B, low phosphate, again, lower phosphate levels are usually protective against calcification, not contributing to it. Option C, magnesium deficiency. Magnesium actually has a protective role against vascular calcification, so its deficiency could worsen calcification, but it's not the primary factor here. Option D, low PTH, low parathyroid hormone levels, can lead to hypocalcemia and other metabolic disturbances, but are less directly linked to calcification. Finally, option E, high calcium, phosphate product. This is a critical concept. When calcium and phosphate levels are both high, their product exceeds a threshold that promotes precipitation and calcification in the vasculature. So, connecting this to the overall theme of mineral metabolism disturbances in chronic kidney disease, the most important biochemical contributor here is the high calcium, phosphate product. It's the main driver of vascular calcification in dialysis patients. Therefore, the best answer is E. The correct answer here is E now. Let's delve into why. A high calcium times phosphate product, or Ca times PO4, actually promotes vascular calcification. This process is quite significant because it can lead to stiffening of the blood vessels, which in turn increases the risk of cardiovascular problems. Essentially, when this product is elevated, it's associated with a higher mortality rate related to heart disease. This point ties into the overall theme of our presentation, which emphasizes the importance of managing mineral levels carefully in patients with chronic kidney issues. By understanding how calcium and phosphate interact, we can better prevent complications like vascular calcification, ultimately improving patient outcomes. All right, let's look at this scenario. We have a CKD stage 5 patient with a phosphate level of 2.4 mmol/L and a corrected calcium of 2.6 mmol/L. Now, the key here is to choose the most appropriate phosphate-lowering therapy. First, we need to consider the options. Calcium carbonate, calcium acetate, sevelamer, calcitriol, and alpha-calcidol are all potential choices, but not all are suitable in this situation. Since the patient's phosphate level is 2.4 mmol/L, which is within the target range, aggressive phosphate lowering may not be immediately necessary. We also have to be cautious about calcium levels because adding calcium-based binders could increase the calcium load, risking hypercalcemia. In this context, non-calcium-based phosphate binders like sevelamer are often preferred, especially when calcium levels are already on the higher side. Sevelamer can effectively manage phosphate without adding to calcium load, which helps prevent vascular calcification. On the other hand, calcium-based binders like calcium carbonate or calcium acetate could be considered if phosphate levels were higher and calcium levels were low. But here, with calcium at 2.6 mmol/L, we should be cautious. As for calcitriol and alpha-calcidol, these are active vitamin D analogs, primarily used to manage secondary hyperparathyroidism, not directly for phosphate lowering, and could potentially increase calcium and phosphate absorption. So, considering all these factors, the most appropriate choice for phosphate lowering in this patient would be sevelamer. It effectively reduces phosphate without increasing calcium levels, aligning with the goal of balanced mineral management in CKD. The correct answer here is C when managing phosphate levels, especially in patients with certain complications. The choice of phosphate binder is crucial. Non-calcium phosphate binders are generally preferred in situations where calcium levels are high or there's evidence of vascular calcification. This is because calcium-based binders can contribute to further calcium buildup in the vessels, exacerbating calcification and increasing cardiovascular risk. So, in these cases, opting for non-calcium options helps control phosphate without adding to calcium load. This approach aligns with the overall goal of minimizing vascular calcification and improving patient outcomes. All right, let's take a look at this question. We have a dialysis patient with persistent secondary hyperparathyroidism, despite they've already managed phosphate levels and vitamin D therapy. The key here is that their PTH levels are still elevated, which indicates that the usual treatments haven't fully controlled the condition. Now the question asks, which medication can directly suppress PTH secretion without raising calcium levels? This is important because some therapies, like increasing calcium-based binders or vitamin D analogs, can sometimes elevate calcium, which we want to avoid in certain cases. Looking at the options, the most targeted treatment for suppressing PTH without affecting calcium is cinacalcet. It acts as a calcimimetic, essentially mimicking calcium's effect on the parathyroid glands, leading to decreased PTH secretion without increasing calcium levels. So the correct answer here is D. Start cinecalcit. This choice directly addresses the elevated PTH, especially when calcium levels are already a concern. It fits into our broader theme of managing secondary hyperparathyroidism effectively, balancing suppression of PTH while keeping calcium in check. The correct answer here is D now. Let me explain why. Calcimimetics work by increasing the sensitivity of the calcium-sensing receptor, which is located on the parathyroid glands. When these receptors become more sensitive, they detect calcium levels more effectively, which in turn suppresses the secretion of parathyroid hormone, or PTH. This mechanism is particularly important in managing conditions like secondary hyperparathyroidism. So, understanding how calcimimetics influence receptor sensitivity helps us see their role in reducing PTH levels and managing mineral imbalance in patients. This ties into our overall theme of targeted treatments for endocrine disorders. All right, let's consider this case carefully. We have a renal transplant recipient who, 1 year post-transplant, is still experiencing hypercalcemia along with very high PTH levels. This suggests that despite the transplant, the parathyroid glands are still overactive. Now, when we see persistent hyperparathyroidism after transplantation, it's important to differentiate between the types. Secondary hyperparathyroidism is common in chronic kidney disease due to phosphate retention and vitamin D deficiency, but it usually improves after transplant. Tertiary hyperparathyroidism, on the other hand, occurs when the parathyroid glands become autonomous after long-standing secondary hyperparathyroidism, leading to persistent overproduction of PTH and hypercalcemia. This scenario points strongly toward tertiary hyperparathyroidism, especially given the high PTH levels and ongoing hypercalcemia a year after transplant. Other options like vitamin D deficiency or medication non-adherence don't fully explain this picture. So the most likely diagnosis here is tertiary hyperparathyroidism. This highlights an important concept. Even after kidney function improves, the parathyroid glands can become autonomous, requiring targeted treatment. It's a key piece in understanding post-transplant mineral and bone disorder management. The correct answer here is C now. Let's break down why that's the case. After long-standing chronic kidney disease, or CKD, the parathyroid hormone, or PTH, can start secreting on its own, independent of the usual regulatory signals. This is what's known as autonomous PTH secretion. And when this happens, it leads to a condition called tertiary hyperparathyroidism. Essentially, the parathyroid glands become overactive and continue to produce excess PTH even after the initial cause, which was the CKD, has been addressed. This is a key concept because it highlights how prolonged CKD can cause lasting changes in calcium and bone metabolism, making management more complex. So, understanding this mechanism is crucial in recognizing the progression of secondary to tertiary hyperparathyroidism in our patients. All right, let's look at this case. We have a dialysis patient with a PTH level over 1,500 picograms per milliliter, which is quite high. This patient is also experiencing bone pain and calciphylaxis, despite being on maximal medical therapy. So, what does this tell us? Well, the elevated PTH indicates severe secondary hyperparathyroidism, and the presence of calciphylaxis suggests advanced vascular and soft tissue calcification. Now, considering the options, the most appropriate next step here is parathyroidectomy. This is because medical management has already been maximized, and the patient's symptoms and complications are severe. Parathyroidectomy can help reduce PTH levels directly, which in turn can alleviate bone pain and slow or stop the progression of calciphylaxis. Other options like increasing calcium intake or stopping phosphate binders wouldn't address the underlying issue effectively at this stage. Emergency dialysis might be necessary for certain acute scenarios, but in this context, removing the overactive parathyroid glands is the most targeted and effective intervention. So, in summary, For patients with such extreme PTH levels and severe symptoms despite optimal medical therapy, parathyroidectomy is the key next step. It's a definitive treatment aimed at controlling the hyperparathyroidism and its complications. The correct answer here is D, when we're dealing with refractory secondary hyperparathyroidism that has led to complications. Medical management alone often isn't enough. In these cases, surgical intervention becomes necessary. This step is crucial because if the hyperparathyroidism is resistant to other treatments and causes significant issues, removing or reducing the overactive parathyroid glands can help restore balance. It's an important point to remember as we consider treatment options for advanced cases. This ties into the overall theme of managing complex mineral and bone disorders in chronic kidney disease, emphasizing when surgery becomes the appropriate course of action. Let's take a closer look at this case. We have a 55-year-old man with CKD stage 3B, and his labs show some interesting findings. His serum phosphate is normal, and his corrected calcium is on the low normal side. His PTH is mildly elevated, and his vitamin D levels are normal. Despite his phosphate levels being normal, he's already showing signs of early secondary hyperparathyroidism. This is an important point because it highlights how the body begins to respond to CKD even before significant changes in phosphate levels occur. Now, the key question here is, which mediator is mainly responsible for these early biochemical changes? In essence, we're asking what drives the increase in PTH in this early stage of CKD. Among the options, fibroblast growth factor 23, or FGF23, plays a crucial role. It acts early to regulate phosphate and vitamin D metabolism, especially in CKD. It helps explain why PTH starts to rise even when phosphate levels haven't increased significantly yet. So, understanding FGF23's role helps us grasp the initial biochemical adjustments the body makes in response to declining kidney function, aiming to maintain mineral balance. Recognizing this early activity is vital for managing bone health in CKD patients effectively. Correct answer, C. In early chronic kidney disease, or CKD, one of the earliest changes we see is an increase in FGF23 levels. This increase actually happens before we notice any changes in serum phosphate or PTH levels. FGF23 plays a crucial role here because it suppresses an enzyme called 1-alpha hydroxylase. This enzyme is responsible for converting inactive vitamin D into its active form, calcitriol. When calcitriol levels drop, it reduces the absorption of calcium from the intestines. This decrease in calcium absorption triggers a response known as early secondary hyperparathyroidism. What's important to remember is that these changes occur even when serum phosphate levels remain normal, highlighting how FGF23 acts early in the disease process to try to maintain mineral balance. Understanding this sequence helps us see how CKD progresses and the body's initial responses to declining kidney function. Let's take a closer look at the overview of mineral metabolism disorders in CKD. This is a complex but crucial aspect of understanding how chronic kidney disease impacts the body. Essentially, CKD leads to a systemic disorder involving multiple factors like calcium, phosphate, PTH, vitamin D, bone turnover, and vascular calcification. These components are all interconnected, and disturbances in one can affect the others. When kidney function declines, it disrupts the delicate balance of mineral metabolism. For example, phosphate retention increases, and calcium levels can become imbalanced. The parathyroid hormone, or PTH, ramps up in response to these changes, which in turn affects bone turnover and vascular health. Vitamin D metabolism is also impaired in CKD, further complicating the picture by reducing calcium absorption from the gut. This cascade of disturbances not only affects bone health, leading to conditions like osteodystrophy, but also promotes calcification of blood vessels, increasing cardiovascular risk. So, understanding this disorder as a whole helps us appreciate why managing mineral and bone health is so vital in patients with CKD. It's not just about bones. It's about preventing systemic complications that can seriously impact overall health. Let's take a closer look at some key biochemical changes that occur in chronic kidney disease-related mineral and bone disorder. First, you'll notice that phosphate levels tend to rise later in the disease process. This is because as kidney function declines, phosphate excretion becomes less efficient. At the same time, calcitriol, which is the active form of vitamin D, decreases. This reduction impairs calcium absorption from the gut, contributing to disturbances in calcium balance. Early on, before we see significant phosphate buildup, the body responds by increasing parathyroid hormone, or PTH. This is a compensatory mechanism aimed at maintaining calcium levels, but over time, it can lead to secondary hyperparathyroidism. You'll also see that calcium levels can vary. Sometimes they stay normal, but they can also fluctuate depending on the stage of CKD and other factors. Overall, these biochemical changes, rising phosphate, falling calcitriol, increased PTH, and variable calcium, are interconnected and form the core of CKD, mineral and bone disorder. Recognizing these patterns helps us understand the complex disturbances in mineral metabolism that impact bone health and cardiovascular risk in these patients. Let's take a closer look at the different bone phenotypes seen in CKD, mineral and bone disorder. First, we have the high turnover type, which is characterized by osteitis fibrosa. This occurs when PTH and alkaline phosphatase levels are elevated, leading to increased bone resorption and formation. It's often a response to secondary hyperparathyroidism. Next, there's the low turnover, or a dynamic bone disease, where PTH and ALP levels are decreased. This results in decreased bone turnover, making bones more fragile and less able to repair themselves. We also see osteomalacia, which involves defective mineralization of the bone matrix. This can lead to soft, weak bones that are prone to deformities and fractures. All these phenotypes highlight the complex ways CKD affects bone health, emphasizing the importance of understanding these mechanisms to manage mineral and bone disorders effectively in our patients. Let's talk about some key management principles for addressing mineral and bone disorders in CKD. First, dietary phosphate restriction is crucial. Limiting phosphate intake helps manage serum phosphate levels and reduces the burden on the kidneys. Next, phosphate binders are often used, and when choosing them, non-calcium options are generally preferred, especially if the patient's calcium levels are high. This helps prevent calcium overload and calcification issues. Vitamin D analogs are also important, but we need to be careful with their use. Since they can increase calcium and phosphate levels, close monitoring is essential to avoid complications. For dialysis patients, calcimimetics can be effective. They help suppress parathyroid hormone secretion without raising calcium or phosphate levels excessively. And finally, if medical therapy isn't enough and the patient's condition remains refractory, parathyroidectomy might be necessary. This surgical option can be a definitive solution in severe cases. All these strategies are interconnected and aim to control mineral levels, prevent bone disease, and reduce cardiovascular risks associated with CKD-related mineral and bone disorder. Let's talk about focus here. Vascular calcification is a significant concern because it directly increases cardiovascular risk in our patients. So, managing this aspect is crucial. Now, when it comes to PTH, we want to avoid oversuppression. Overdoing it can lead to other complications, so it's all about finding that right balance. Monitoring trends over time is more valuable than fixating on single values. A single measurement might not tell the whole story, but tracking how these levels change gives us better insight into the patient's progress and helps guide our treatment decisions. This all ties into the broader topic of CKD, mineral and bone disorder. Managing mineral levels carefully is key to preventing complications like vascular calcification, which links back to the overall cardiovascular health of our patients. So, keeping an eye on these factors, understanding their interplay, and adjusting our approach accordingly is essential for optimal patient care. Let's start with pearls about PTH and phosphate in CKD. First, PTH tends to rise before phosphate levels become abnormal, which is an early indicator of mineral imbalance. Next, it's important to remember that high calcium combined with high phosphate significantly increases mortality risk in these patients. However, low PTH doesn't necessarily mean everything is fine. It can actually indicate a dynamic bone disease, where bone turnover is too low. So, we need to be cautious when interpreting PTH levels. Now, cinacalcet is a useful medication because it lowers PTH without causing significant increases in calcium or phosphate levels, helping us manage secondary hyperparathyroidism more safely. In cases of persistent hypercalcemia after a transplant, this often points to tertiary hyperparathyroidism, which can be quite challenging to control. Lastly, even if phosphate levels are normal, we can't rule out Ckd Mbd. Early disease is often driven by elevated FGF23, which suppresses calcitriol production, leading to subtle but important mineral disturbances. Understanding these key points helps us better manage mineral and bone disorders in CKD, ultimately improving patient outcomes. Thank you so much for your time and attention today. I really appreciate the opportunity to share these insights with you. Remember, the key takeaways are all about understanding the core concepts we discussed and how they connect to the bigger picture. I hope you found this presentation valuable and that it inspires you to apply these ideas in your own work. Thanks again for being such an engaged audience.